Hi everyone, today's presentation is about the data linkage work on readmissions and ED presentation after an epilepsy hospital admission for people with intellectual disability. Here I refer to ID. ID is defined by the impairments in the overall level of intelligence and adaptive functioning, which should manifest during the developmental period. The prevalence of ID is estimated to range from 1% to 3% around the world. It has been found to inflict substantial health burdens on the individuals, families, and the society. People with ID often have suboptimal health outcomes, including high mortality rates and susceptibility to certain health conditions. One major condition is epilepsy. As was estimated, on average, 22 in 100 people with ID may live with epilepsy as well. This risk is up to 33 times higher in comparison with that in the general population. Evidence also shows that the presence of epilepsy can further increase risks of other comorbidities for people with ID. Therefore, it's conceivable that this specific group may experience very complex health needs. Caring for epilepsy is very challenging, so that people with ID often have their health needs unmet in the current healthcare system. This mismatch between needs and services could lead to suboptimal health and healthcare outcomes, such as more frequent hospitalizations and ED presentations, and even more deaths. In light of the significance of epilepsy issue in people with ID, efforts are needed to address this gap to reduce related burden. However, little research has been done in this area. To address this issue, our first step is to better understand health needs and healthcare use of people with ID and epilepsy. In this specific piece of work, our objective is to depict the short and long-term health service use trajectories for people with ID when they have an epilepsy episode and are urgently admitted to hospitals. Specifically, we aim to answer the following question. Of people with an admission to hospital for epilepsy, do those with ID have a higher risk of all-cause readmissions, readmissions for epilepsy, and ED presentations? Our study mainly used 3 data sets to derive the study population and variables of interest. Our study population was derived from New South Wales admitted patient datasets, from which we extracted patients aged 5 to 64 who had at least one unplanned admission with a primary diagnosis of epilepsy in New South Wales between July 1st, 2005 and June 30th, 2014. By combining the New South Wales admitted patient dataset with disability dataset and the New South Wales Emergency Department dataset, we were able to identify those with ID who have ever received disability services in New South Wales or have ICD-10 ID diagnosis codes in the admitted patients and ED presentation datasets in New South Wales Hospital. To balance the effects of different age and sex distributions, patients with and without ID were matched by age and sex using coefficient exact matching. Under this matching strategy, every non-ID patient is matched with an ID patient of the same age group and sex. The number of people in the same age and sex group were weighed up in the analytical model. We followed the participants from the discharge from the index epilepsy admission to 30 days, 90 days, and a year to look at the risk of all-cause readmissions, readmissions for epilepsy only, and ED presentations. We also identified important covariates from the admitted patient dataset, including demographic characteristics, socioeconomic status, characteristics of the index admission, and health status of patients, including comorbidity situations. The final cohorts consist of around 13,000 patients aged 5 to 64. Among them, 19% were with ID. Compared with those without, patients with ID were younger, more likely to be Australian-born, be in the middle socioeconomic status. They were also more likely to have admission in the previous year, have psychiatric comorbidities, and have status epilepticus at index admission. On the other hand, they are less likely to be covered by the private health insurance at index admission, and they were also less likely to have high Charlson comorbidity index. This table shows the proportion and risks of having all-cause readmissions within different follow-up times in epilepsy patients present without ID. There were 14% of patients with ID experienced at least one readmission within 30 days, 25% had readmissions within 90 days, and half of patients with ID have returned to the acute inpatient care in a year after discharging from an epilepsy admission. The proportions of readmissions were higher in adults than in children. We compared readmission rates between ID and non-ID groups for all patients, children, and adults by fitting a modified Poisson regression model. The adjusted relative risks shows that the readmission rates in both short and long-term follow-ups are significantly higher in patients with ID than that in those without ID. The increase in risk only became insignificant for 30-day readmission for children with ID. Among those who had at least one all-cause readmission, we summarized the primary diagnosis of the first readmission, finding that neurological disorders and symptoms and signs and respiratory disorders were the leading reasons for patients with ID, regardless of age. Besides, infectious disorders are also specifically prevalent among children, and readmissions for mental health disorders and injuries were also prominent in adults with ID. When compared with patients without ID, we found that readmissions for neurological disorders and respiratory disorders were overrepresented in patients with ID regardless of age, and infectious disorders were overrepresented in children with ID. We then specifically analyzed the risk of epilepsy readmissions, also finding around 50% high risk of readmission for epilepsy in all patients with ID compared to those without. And this increase in risk can also be seen when stratifying data into adults and children. The only insignificant relative risk was found for epilepsy readmission within 30 days for children with ID. In addition to a readmission, we also look at data for proportions and risk of ED presentations, finding alarmingly high rates. More than 60% of patients with ID presented to the emergency department within a year, regardless of age. However, compared with patients without ID, the risk of ED presentations only increased marginally to slightly in most of the cases. In summary, we found that within both short and long-term periods after an epilepsy hospital admission, patients with ID are more likely to experience readmissions for all causes and for epilepsy only, and they are also more likely to experience ED presentations compared with patients without ID. We also found overrepresentations of neurological, respiratory, and infectious disorders for readmissions in patients with ID. These results partly reflect the more complex nature of epilepsy among patients with ID, regardless of age. This is in keeping with existing evidence that people with ID have more severe and retractable epilepsy. It may also imply the potential undermanagement of epilepsy at the primary healthcare level. Our results suggest a need to improve epilepsy management for patients with ID, and healthcare systems should be better prepared to cater for the needs of patients with ID with a holistic view. There are several strands of our study. First, the use of multiple dataset linkage enhances the ability of identifying people with ID. Second, the longitudinal data collection enables the identification of healthcare service use for individual patients. Our comprehensive dataset also allows us to extract information about several important covariates. This study also has a few limitations. The first is the inherent drawbacks of a demonstrative dataset, including recording mistakes and the representation of the mild ID. Second, we were not able to get some other covariates that are also important, such as the accommodation situations for all participants. Furthermore, our datasets don't have clinical information either, which is also valuable in the epilepsy research area. But we're hoping to address some of these issues in the future work by including more other health datasets. That's it for today's presentation. Thank you for listening, and feel free to reach me and ask any questions.